Good morning. Welcome, everyone. My name is Rebecca Lee, and I serve as Vivli's CEO. It's wonderful to see so many of you here for our annual meeting. So those of you in the room, as well as, I understand, a number of participants online. Julie, could you let us know? I know there are participants from globally and from a number of different countries. Do you have any stats on that?
Yes.
Sure. Come on.
So those who are joining us,
We'll raise it a bit.
So for those of us who are joining virtually, we have a little over 57% of the participants joining from North America. A couple of people who have clearly are interested in joining us from Asia, and then the rest are from Europe. So a big thank you for everyone who's joining us virtually as well. There will be a chance for those attending virtually as well to ask questions. And then we have the second poll. For those of you in the room, if you can see that on that monitor, that's the results, but everyone who's online can see the results as well.
Okay. Bringing this down to my level now. Thank you, Julie. Julie Wood is our CEO, and keeps things running also. I want to acknowledge our team today. So this is my favorite time of year, a time for us to reflect on our previous year, a time to learn from everyone, whether you're in the room or online, and a chance to look forward to our next year as well. It's been such a wonderful year of growth for us as we've done this together. And what makes today special is really the group of people that have come together to make this happen. Data contributors, researchers, our partners, and of course the Vivli team, who I want to give a special thank you to. At the heart of Vivli are two complementary platforms. So most of you in the room probably are very well aware of our Vivli clinical trial platform, within which we share clinical research data. We also, since the last 3 years, have launched the AMR, or antimicrobial resistance platform, for industry surveillance data. This was launched with funding from Wellcome Trust. You'll hear more about the AMR platform in our data challenges section today, and I think that'll be interesting for you to catch up just a bit on what we're doing there as well. So when we think about looking on the past year since we last met, what strikes me are not the numbers in themselves, but the momentum behind the numbers. We've seen steady, measurable growth in every single tangent of where we are, whether it be data contributors. So we've had a growth in data contributors, and they're contributing even more research across a diversity of data types. And so we have more depth and more breadth in the types of research that's been shared. Research usage on the platform has also increased sharply, as you can see here. So in terms of the number of trials accessed, proposals put in, as well as our publications. At any one time, we have about 400 research environments running. So what does that mean? That means there are 400 teams actively analyzing data within the platform. So in terms of where we are with requests for data, and I think just diving in a little bit more, we can see a diversity of therapeutic areas where the data comes from, led by oncology and endocrinology, as well as cardiology. But of course, there is therapeutic breadth in what researchers are requesting from us over time. When we think about data reuse and publications, as well as our global reach, we look at, for example, one publication, 5 and 10. We see that over the last 5 years or so, we've grown in terms of the regions and the countries that are represented and that have been contributing to data reuse for Vivli. Clearly, North America and Europe are the foundation upon which we are going to continue to build. Asia is also contributing, and we see a significant contingent coming from some of the countries in Asia. We do see some gaps as well, and that's where we will focus our outreach in the coming years. This graph shows our approved requests. So we see a breadth of reasons of why people are coming to us and requesting data. So for the most part, they're requesting data for new research, whether it's to look at effectiveness of a treatment or safety, meta-analysis, doing some methods work, for example, in AI or ML. Some are coming to confirm research, so about 19%, supporting trial design or training. In the next segment, I want to talk about what we think about as the impact of data sharing. Now, many times people might think of, if you look at how people have historically captured the impact of data sharing. That's been perhaps views or downloads for repositories. Publications is also one way that is a hard metric, right? I just showed you we can easily capture publications. That's on our metric board. But we decided to think about going beyond simply publications and look at the real outcomes. So we did a study in looking at putting all of the requests and public disclosures into 7 buckets. And for example, informing patient care decision-making or clinical guidelines, which is really a gold standard of how someone might use the data for designing future clinical trials, for example. I used to be a clinical trialist, and I wish there was something like Vivli around back then so I could do something like that. So each data request was coded to one of these outcome responses, and we can show you the data. So here is what I think of as the real outcome of data sharing. So you can see there's a significant proportion that is focused on informing patient care decision-making or tools. If I had more time, I'd give you a case study for each one of those, and that's probably another presentation. All the way down to designing trials, algorithms, and code. Others might be, for their graduate student, because they're a grad student and they want a project, funding applications. So there's a quite variety of why those of you who are contributing data, this is the reason why you're doing it. This is the real impact. I want to spend the next few minutes talking about key initiatives that will be driving what we see as the next chapter of Vivli. And there are 4 of them. First of all, expanding our imaging capabilities. We have 2 segments focused on imaging. We discussed this last year as something that was on the horizon, and I think that's become a bit of a reality this year. So integrating imaging into the platform, as you can imagine, with oncology, neurology, and a number of other therapeutic areas. Without the images riding along with the tabular data, researchers are only seeing half the picture. So that is something that we focused our efforts on, and we do see that growing in the next few years. The second is in advancing AI and ML responsibly. We had a fairly intense work group this past year focused on AI and ML. So what does that mean? It means enabling innovation while safeguarding privacy. We realized that when we started Vivli, there were no requests coming in with any elements of AI or ML. And that's probably not surprising, we're 8 years old. Now in our 8th year, approximately 20 or 25% of all proposals have some element of AI or ML. So how do we enable innovation while still safeguarding privacy as these models that are coming in are increasingly complex? So this is what we focused on, and we have a framework that manages the models as well as how the data is exported. We've launched the Vivli Ambassadors Program. That was largely spearheaded by Julie, so I want to give credit where credit is due. And a number of them are here today. We are delighted to see them and certainly introduce yourselves to them as well. So Dr. Saal, Dr. McAllister, Zeidan, delighted to have you in the audience and participating in our panels today as well, to hear directly from our ambassadors, our researchers who are utilizing the data. So as part of the growth this year, and I'll invite our board chair, Dr. Mike Stebbins, up with me as we talk about this next segment in terms of, oops, I don't know where that came from, in terms of our global engagement. Part of our growth this year in increasing global engagement, we are laying the groundwork for a new entity, a Vivli entity in Europe. We believe this as a continuation of our current mission to connect data, partners, and researchers across borders. And this is simply a natural evolution in our next chapter that we will call Vivli EU, which will be based in Amsterdam. I'll invite Mike to come up and say a few words on behalf of our Vivli board. Mike?
Thank you very much. So, like most of you, the board is completely delighted with the growth of Vivli over the last 8 years. I think we're at 8 years now, right?
Yes.
So, so this morning the board voted to expand that global commitment, and we have approved the establishment of Vivli EU in Amsterdam, as Rebecca said. This commitment is something that we're going to launch in the next couple of months. So we're not looking at years to get this done. We're going to be functional in the EU within the next couple of months. And we're delighted with that expansion of efforts in the EU and really a continuation of the global commitment that Vivli has made to responsible data sharing. So just wanted to put a pin in that. And also really wanted to again highlight how extraordinary the Vivli team is, especially under Rebecca's leadership, and the entire team is really to be credited with this growth and with this expansion. So thank you very much, Rebecca, and thank you to the entire Vivli team on behalf of the board. This has been an extraordinary step forward and is going to be a real catalyst for a dramatic growth of Vivli's footprint in the data sharing space. So thank you again.
Thank you so much, Mike. So on to our agenda for today. I think we have a really special program for you that brings together not just the data contributors, but the data requesters as well. And you'll hear directly from both groups, the contributors and the researchers, those on both sides of the data sharing equation. And I think that's what will make today very special, how their work is making a global impact. We have a specific session devoted to data challenges, and I'm hoping that will really motivate others in this room as well to think about how might a data challenge impact you or your team or your data. So we'll be spotlighting those in a few interesting sessions this morning. I think it'll be an inspiring day. I'm really looking forward to it. So thanks again to all of you for being here, and let's get started. I'd like to next bring up Murray Stewart, who is part of our board and will be moderating the next session. Murray. Oh.
Great, thank you.
Sorry.
Rebecca, can I invite my panel members to come and take their seats? So you can see from the slides that Rebecca showed, the first thing I find is really exciting is that data sharing is now starting to impact patient care. So it was great to see over 60% of the data making an impact on patient care, because that's one of the main reasons we wanted to get people to share data. And another thing you could see from Rebecca's slides is that 30% of the data requests are related to oncology. So I don't think it's a surprise that we wanted to kick off this morning with some data from oncology. So I'm delighted with my panel before me, and we're going to have probably two talks around the data, and in between we'll have some practical discussions about the challenges and the benefits of sharing data. But without further ado, I'd like to invite the first speaker, Jonas Saal, a hematologist and oncologist from the University of Bonn in Germany. Jonas, do you want to come up?
Okay, good morning. Thank you for the introduction, and special thanks to Vivli for inviting me to talk about my research in this meeting. So I'm going to talk about one of my projects that I did using Vivli data, and it's called Establishing a Multimodal Response Assessment Framework for Cancer Immunotherapy using Clinical Trial Data. I'm going to keep the introduction short to get to the data sooner. So cancer immunotherapy, most of you have probably heard of it by now, is based on the concept that the inhibition of immune checkpoints that are expressed on T cells can enable these T cells to more effectively attack cancer cells. And this is a very effective way of treating cancers and has really revolutionized solid oncology, especially over the last 15 years since the first drugs were approved. This is an example in non-small cell lung cancer where you can really see that pembrolizumab, one of these checkpoint inhibitors, really can prolong survival in a very durable fashion for many patients. However, there are still 70% of patients in this example that progress within 2 years. So there still is a significant unmet need. And one of the big problems is that we do not really have a good way to identify those patients beforehand or early on. So we are still lacking biomarkers. And one reason why we might not be there yet is that the current way of looking at tumors and also assessing tumor responses is what I would call tumor-centered. So we look at the tumor burden, so mainly using imaging, we look at genetics, we look at histology, but the problem with this approach is that the immune checkpoint inhibitors don't kill the tumors themselves. They only enable our immune system to do so, and therefore the mechanism of action is much more complex than just targeted at the tumor. And this is why I believe that a more patient-centered approach, a multimodal approach, is very promising in this space. And that means is that in addition to the tumor-specific factors, which certainly are very important, we also look at metabolic factors affecting the patient and also immunological factors, the immune fitness that these checkpoint inhibitors can then harness to attack the cancer. And one very simple way to look at the patient in a very broad fashion is the Modified Glasgow Prognostic Score, or MGPS. It's a very simple clinical or laboratory score that just uses two parameters, C-reactive protein, a broad inflammatory marker that correlates well with chronic inflammation, to a certain extent even with tumor biology, and albumin, which is a very broad, mainly metabolic marker that also correlates with inflammation and with general fitness. So what we did is, in the first step, we assessed whether this MGPS can predict survival, in this example, in renal cell carcinoma patients that are treated with immunotherapy. And what we could show is not only that the response or the survival prediction is really effective using this MGPS, we could also show that this MGPS is superior to the current clinical standard, which is the IMDC score that consists of 6 different parameters. So we simplify the risk assessment, and it's still more powerful. But we took it one step further and reassessed this Modified Glasgow Prognostic Score at the time of the first response assessment. So with cancer patients, after starting treatment, you usually reassess the treatment within 6 to 12 weeks. In this trial, it was done after 12 weeks using imaging. And what we did is, within the subgroups of patients that had a certain MGPS risk group at baseline, we looked at the different risk groups after 12 weeks. And we could see that still within these subgroups we get a lot of additional prognostic information. And thereby we could show that reassessing these markers on treatment can really refine our outcome prediction. And we were able to show that across multiple different cancers. This is an example from urothelial carcinoma. And here we actually divided the patients by their response according to imaging criteria. So to the left, you see only patients that are classified as stable disease according to the RECIST criteria. And you can see that even within this subgroup, in which we don't have any additional information from the imaging, by now we can really get a very good split of the curves, a lot of prognostic information. Did the same thing for non-small cell lung cancer. Here we have had the opportunity to look at it at 2 different time points, 6 weeks and 12 weeks on treatment. And we really saw basically the same thing. It's a very consistent signal. And just as one example number here, so the 12-month overall survival in the group that progressed on treatment but had a low-risk MGPS score was 85%, which is really a lot, considering that this is a second-line trial for non-small cell lung cancer, and most patients in this situation die very quickly. So the MGPS is really powerful at finding low-risk subgroups. When we combine the MGPS with imaging, we can see that here patients with stable disease, or SD, that have an MGPS intermediate or high risk have actually even a slightly higher risk of dying from their disease compared to those who progress on imaging but are low risk on the MGPS. So this again shows the potential also of the combination of this multimodal concept of doing imaging and laboratory work-based response assessment. We also looked at it from a slightly different perspective. We termed this the PD MGPS, which is the MGPS assessed at the time of the first disease progression on treatment. So once the tumor is growing on the CT scan, we look at the MGPS. And what we could show here is that this really correlates very well with the time the patients will survive after this disease progression. So why is this important? With immune checkpoint inhibitors, it's a very common thing to treat beyond progression, so to continue the immunotherapy despite the tumor growing. It's common practice, it's allowed in almost all clinical trial protocols by now, but there are no guidelines on how to do it. Nobody really knows which patients profit. Most protocols state something like observed clinical benefit, but that's a very objective thing. And so what we did is we looked at whether our PD MGPS could be predictive in this setting. And indeed, we could show that only patients with a low-risk MGPS at the time of progression actually profit from the continuation of immunotherapy compared to switching them to another treatment. And patients with intermediate or high-risk MGPSs did not profit. And to my knowledge, this is the first objective biomarker that has shown predictive value in this setting. One big advantage of the MGPS is that it's really cheap, compared especially to other modern biomarkers that are based on sequencing, DNA, RNA multimodal assessments. So the cost in the US is $10 to $20. So it is also feasible to repeat this regularly, and it's not a big deal to include these measurements into response assessment. Also, of course, the research that led to this was very cost-effective because it used existing data. And yes, so in summary, we could show that this MGPS can actually improve the prognostic value of our current standard, the imaging-based response assessment, across multiple solid tumor entities. We could show that the PD MGPS, the MGPS at the time of disease progression, can be able to distinguish those patients that profit from continuation of immunotherapy from those who don't. The MGPS is a very attractive biomarker because it's cost-effective, it's widely available. These two markers are really measurable in any clinical laboratory. It's easy to implement. And of course, this research was only made possible because of clinical trial data sharing. Thank you.
Jonas, thank you very much. Really clear presentation. and great findings. What are the next stages? Do you hope these will be adopted in guidelines, and what further research will you do?
It would be great if it was adopted in guidelines, but I think the nature of this research is still retrospective, although it's using randomized clinical trial data, which is, I think, a very high data quality standard. But still, before this can really be implemented into clinical guidelines, there would need it to be prospective data. Ideally, for example, for the PD MGPS, there would ideally be a randomized trial that really looks at different strategies based on this PD MGPS. But on the other hand, there are many clinical decisions that are not clear and where you don't have clear guidelines, like, for example, the continuation of immunotherapy. And I think in this space, these simple markers, because they virtually cost nothing to assess, can really be helpful to clinicians. And so I think that this already can have an impact. And for me, in my clinical practice, I don't base my treatment decisions on the MGPS, but I look at it and I take it into account.
Okay, thank you. Thank you again. Let's move on to our next speaker. Before I do that, I want to say the next three speakers are probably going to cover more of the practical aspects of data sharing, including some of the benefits and some of the challenges. So there won't be questions in between. We'll move between the speakers. So the first one, hopefully, if our technology is working, is Jen O'Callaghan, responsible for data privacy and sharing at Roche. And she's virtual, so hopefully the technology will work. Jen, over to you.
Thanks, Murray, and good morning to everyone there, and good afternoon from Switzerland at Roche HQ. So I'm going to briefly speak about the tension between complying with data protection regulation and data sharing. So Vivli provides us with a secure access mechanism, which is very beneficial for sharing individual participant level data in compliance with the EU General Data Protection Regulation through several key mechanisms. So firstly, Vivli provides us with a controlled access mechanism for data sharing, and it also provides an audit trail. So researchers obviously must submit requests, and only approved users gain access in a monitored virtual environment. And this really directly supports GDPR principles of integrity, confidentiality, and accountability. Secondly, it also addresses data minimization and data privacy by design requirements of the GDPR. So the Vivli process ensures that only the minimum necessary data is shared and that data are anonymized. And this really aligns also with GDPR's privacy by design requirements. Thirdly, Vivli also provides strong technical and operational measure or organizational measures. So the platform obviously uses encryption, user authentication, and activity logging, which fulfills GDPR Article 32 on the security of processing. And lastly, but not least, Vivli offers a very robust governance and legal framework. The standardized data use agreements and governance oversight helps clarify the roles of data controllers and processors and ensures the lawful data processing. However, GDPR's strict rules on personal data transfer and re-identification risk do mean that we often can't share as much data as we would like, particularly rich clinical or genomic data sets that could potentially re-identify individuals. And additionally, there can also be country-level restrictions, which also mean that it's not always possible to share all data from all countries in global trials, which may impact reproducibility and also impact scientific and analytical value. So balancing data utility and privacy protection does remain difficult, and more de-identification can obviously reduce analytical value for the scientific community. So while Vivli's secure access model is a really strong enabler of GDPR compliant data sharing, protecting participants' privacy and building trust, it also highlights the ongoing tension that we experience between data protection and research innovation. So the challenge is finding ways to maximize scientific value while fully respecting the rights and safeguards that GDPR demands.
Great, thanks, Jen. I'll move on to Paula Boyles now, who's responsible for external clinical trial data sharing at Pfizer. Paula.
Yep, thanks, Murray. So you heard from Jen really about how we share our data through Vivli. I often get asked, why do we even share data to start with? And I think fundamentally, from a sponsor perspective, we're sharing the data to advance scientific discovery. You know, we all have the same goal. We want to find new cures. We want to find new treatments. And as you heard from Dr. Saal, you know, the ability to share that data and for external researchers to use that data really advances scientific discovery. And in addition to that, I think it helps to improve the transparency and it helps to build public trust. You know, for those of you who were here yesterday at the MRCT annual meeting, we hear that, you know, the pharmaceutical industry is not trusted. It's one of the lowest trusted. And so I think being open with our data, being willing to share that, have it open to scrutiny. I'm sorry, I'll get closer. You know, sharing the data and having it being open to scrutiny, having external researchers be able to verify the results, all helps to build that public trust, and ultimately that's what we're looking for. And also from a ethical perspective, I think when we share our data, we're really you know, respecting the contributions of our participants. You know, they put a lot of time and effort into the clinical trials, and I think it honors their contributions to those trials by really maximizing the utility of their data. And, you know, essentially with the appropriate consents in place, that participant can continue to keep giving back to medical research. So there's clearly some strong advantages, but as you heard from Jen, there's always challenges that come with it. And the one I wanted to mention today, you actually heard Julie mention Rebecca mention in her introduction this morning, and that's around the use of clinical trial data with AI. From a sponsor perspective, we have a responsibility to protect the identity of our participants. And I think the biggest risk that we face with AI having the ability to combine so many different sources of data and do very intelligent analysis, but in combining all those sources of data, we do run the risk of re-identifying participants, especially when we have, you know, rare disease populations or small populations for our studies. So that's something that we're certainly cautious of.
Okay, thanks, Paula. And lastly, in this section, Ben Rotz, the medical policy at Lilly.
Thanks. Thanks, Murray. And I'll pull the microphone close to me so you don't have to push it up. Hello, everybody. So we're following too many great speakers already this early in the morning, and so I'll do the best that I can to talk a little bit about some pros and cons. But one of the major pros of the Vivli platform, or the data sharing environment as a whole, is really the ability to do these kind of meta-analyses, or these abilities to take data from multiple clinical trials across multiple companies and test hypotheses. You know, if this environment didn't exist, then we wouldn't be able to do that. And this really allows for the opportunity to do, as Paula has stated, you know, provide the opportunity for science to advance and honor the contribution of the participants from our clinical trials. You know, that's a key aspect of when I talk about it at my company, what we're able to do. I think the Vivli platform also allows for us as a sponsor to do it without putting too many resources to it. You know, we're all very resource constrained. And the company's going to say, I'm only going to put so many resources to any individual thing, and this is not a profit-driving enterprise. So what we have here is an opportunity to work with a great group of individuals at Vivli who really make this happen and facilitate the work, which was not necessarily the way that it worked in the previous format that some of us started in 2013, 2014. So I appreciate that. From a another pro perspective, and I think this is just something that I have because I also have responsibility for externally sponsored research. We get a lot of requests at the company to help fund or to help support retrospective real-world analyses using registries or electronic medical records. We don't get a lot of requests for access to fund clinical trial data, and that kind of surprises me. And I think we're going to probably see that, hopefully, in the future, and say we can combine these two opportunities. Yes, we'll provide some funding to help you, but you're going to access it through Vivli. And hopefully we can, provide those opportunities so individuals like Dr. Saal can do the research that he is doing and really help advance the clinical care of patients, because that's the ultimate goal too, is that we make a difference for the patients. From a con perspective, Paula talked about the questions, why are we doing this? Well, we still get that question internally. I'm constantly having conversations, and more importantly, Tracy is constantly having conversations with individuals at the company of why are we sharing this data? Well, what if another company wants to access it, or what if they're going to try and find something that they're going to use in a competitive perspective? That is a constant thing, and I wish it wasn't. So I think we just need to continue to describe the value, continue to show the opportunities, and blatantly steal slides from Rebecca when she presents them to give our opportunity to show the value at the company.
Great, thanks, Ben. And there'll be an opportunity later to ask questions of Jen, Paul, and Ben. But I want to move to Youssef Zeidan, a radiation oncologist from Florida, who will take us back to some data. Youssef.
Right. So let's see, hopefully my slides will show. Should I just click? Here we go. Okay. Good morning, everyone, and thank you for being here in the room and also for joining us online. It's my great pleasure to be part of Vivli's annual meeting. My name is Youssef Zeidan. I'm a radiation oncologist at Baptist Health, South Florida. This is a photo of our beautiful cancer center in Boca Raton, Florida. It's sunny most of the year, like this in this photo, so this is very cold for me. So what I wanted to do here today, I know I have very short time when I keep the meeting on time, so rather than focus on the deep science here, I wanted to give a little flavor of the science that we've been doing with Vivli, focusing also on the journey of the people who've been working with me on the Vivli platform. So I'll be focusing more on the mentorship side and the career promotion side of the people who are working on research on the Vivli platform, and also give you a little taste about the breast cancer research we've been doing with Vivli. So my journey with Vivli dates back to 2018, so about 7 years that I have to summarize in 8 minutes or so. So back then in 2018, I was a junior faculty member at the American University of Beirut in Beirut, Lebanon. And at the time, we were fascinated with the evolution of targeted therapies for breast cancer. But there's an evolution, and the evolution we're still living until today. And as a radiation oncologist, we wanted to ask the question, what would be the impact of radiation therapy in the setting of such effective systemic therapies for breast cancer? So between 2018 and 2021, we had a very productive journey with Vivli. We had a total of 4 projects approved. In fact, I was even an early adopter, what Rebecca and Julie tell me today. I was with Vivli from the CSDR days and then transitioned to Vivli, so I'm glad to hear that. We had 4 projects approved, but much more happened along the way. So a pandemic, which we all had to live through, a crisis, a local crisis happened in the country, and a move for me and my family, shown here in the photo. So in 2021, we had to move to Florida, and we decided, like everybody else that did during the pandemic, that the show must go on. So in the next few slides, I'm going to give you an example of each one of them. So one project, one slide, and then an example of who worked on the project and where they are now. So the first project was led by a medical student at the time. His name is Dr. Joseph Abijaude. He's now a resident physician in radiation oncology at Stanford in California, the Harvard of the West Coast. So the question at the time was, is there a benefit for patients with HER2-positive breast cancer that receive a radiation therapy boost to the lumpectomy cavity? So essentially, women with early-stage breast cancer, most of them go to receive radiation therapy to the whole breast, but then some patients benefit from addition of a radiation therapy boost to the lumpectomy cavity, like the area shown in blue on the diagram. So we asked this question in the setting of very effective systemic therapy with trastuzumab for the HER2-positive breast cancer patient, which actually improved outcomes in HER2-positive breast cancer tremendously. Is there a benefit for adding this additional boost? So Vivli kindly provided data from the HERA trial, and this was from Roche to Vivli, then to us. And we had 1,000 patients analyzed, and we found that with this subset of patients, the curves are absolutely overlapping over a period of 10 years, and there was no additional benefit from adding a radiation therapy boost. Second project was led by Dr. Bashir, who is currently a postdoctoral fellow in Cleveland Clinic in Ohio. And here we looked at the cardiotoxicity of patients getting radiation therapy and HER2-targeted therapy with trastuzumab. So we divided the data set to 3 categories of patients: patients getting left-sided breast cancer radiation therapy, those getting right-sided breast cancer radiation therapy, and those that are receiving no radiation therapy at all. And looking at the curve on the right side, we found the cardiovascular events were highest for those getting left-sided radiation therapy as compared to right-sided or no radiation therapy, although the absolute differences were very small, suggesting that if you carefully plan your radiation therapy, you could do a good job in avoiding the heart, but still there is a small incremental increase in cardiovascular events down the line. So in the third project, we shifted gears to even a more aggressive form of breast cancer, the so-called triple-negative breast cancer. And this project was led by Dr. Majd Kayali, also at the time a medical student working with me, and he's currently a cardiology fellow at St. Vincent Hospital in Ohio. And here in this data set, we asked whether patients that have limited number of axillary lymph nodes involved with breast cancer, and they receive axillary dissection and novel systemic therapy after having mastectomy for breast cancer, do they benefit from post-mastectomy radiation therapy? And kindly, the Vivli platform provided us with data from the Beatrice trial, which investigated Avastin at the time, or bevacizumab. And here we found with this data set that those patients that have limited axillary nodal disease and receive modern systemic therapy after their mastectomy, the benefit of post-mastectomy radiation therapies was very small, suggesting that very few patients benefit from such therapy. So in the fourth project, I want to spend on it some time here because this project, as Rebecca and Julie pointed out earlier, actually made it to the clinical guidelines. So it was one of those that was so impactful that it was cited in the recent guidelines for radiation therapy for breast cancer that was endorsed by societies of surgeons, radiation oncologists, and medical oncologists in the US. So this project was led by Dr. Omran Saifi, who is currently on his first junior faculty position at MD Anderson in Houston, Texas. So what we investigated here is those patients with HER2-positive breast cancer that receive neoadjuvant therapy, so those that receive very effective systemic therapies before they go to surgery with treatments like trastuzumab and pembrolizumab. Pertuzumab. So specifically those patients that convert from node-positive disease to node-negative disease, do these benefit from post-mastectomy radiation therapy? And here, with data from the Trifina and Neosphere trials that looked at neoadjuvant therapy for HER2-positive breast cancer, we found that there's very little benefit for adding post-mastectomy radiation therapy in those that achieve a complete response to neoadjuvant, that convert from nodes with disease to nodes with no disease at the time of surgery. Whereas those that still harbor residual cancer cells in their axillary lymph nodes at the time of surgery, they did benefit from addition of post-mastectomy radiation therapy. And this was one of the cited evidence in the recent post-mastectomy radiation therapy trials guideline that went out last month. So the point I wanted to drive home today is that data sharing goes really a long way in the modern era. It's really, it is very impactful for generating new science, new ideas, changing guidelines, but also it is very effective in crossing borders and mentoring the next generation of researchers and scientists. I think what we're doing here, as much involved and advanced it seems, I think we're just scratching the surface of the barrel. I think there is much more to do, and the way is still long ahead of us. But it's really exciting time for us all to be thinking what we could all do together with data sharing. And the message I really want to send out today is please keep calm and share your data because it is impactful. So with that, I really want to thank the Vivli team who have been a great partner throughout this 7 years journey, and I look forward to many, many years working together. Rebecca Lee and Julie Wood and all the Vivli team, thank you. And I really want to thank all the patients who enrolled on these trials and gave part of themselves, because without them, none of this would have been possible. Thank you.
Youssef, thank you very much. I mean, how do you actually persuade all these people to use the Vivli? You've been very eloquent in the examples you've given. What advice do you give to a young researcher who says, should I use Vivli?
Yeah, no, a great question. And you know, as a junior faculty, and I'm sure all faculty members that are sitting here, we get a lot of motivated medical students, and I was very fortunate to work with very brilliant medical students. Some of them definitely are going to make it way more than I did during my journey. And so you know, it really takes motivation from the person who is interested in asking a relevant clinical question. So the first thing I tell them in terms of advice is focus on asking a good clinical question. And a good clinical question meaning it is novel, it does have an impact, and it is achievable. So once you have all three comments. Once you've done that, you really have to form your team, because research doesn't live on an island. Good research is collaborative. You really have to find a very dedicated, you know, not a huge team, but a reasonable team in order to get you to the answer. So a good question and a good team. Yep.
Great, Youssef, thank you very much. And Youssef and Jonas, really thanks for sharing clear examples in the oncology area where the data sharing of Vivli to answer broader questions has really been impactful. So it's a great example. And hopefully that's motivated many of you to say, wow, I want to use the Vivli platform. And then you come back to, well, how do I go about it? So I want to ask questions of Jen, Paul, and Ben. And first of all, Jen, this tightrope you've got to walk between sharing data and privacy. A lot of people are worried about the safety aspects and want to protect the data. How do you persuade them that it is okay and the data will be protected?
I guess the clinical trial journey and the clinical trial data sharing journey, we have a responsibility to our patients. They sign up to a clinical trial, they sign up in the ICF to how they want their data to be used. So that's the cornerstone. And I think Paula alluded to this as well when she spoke earlier. The ICF is the license to share data or not. And it's really about respecting the input that patients have put to the trials and what their wishes are as well, to respect those.
Okay, thanks very much. Paul, I want to come to you. You touched on AI. People are maybe mixed feelings about it. How do you think we should embrace it to move ahead?
Yeah, well, I think, we don't really have a choice. Quite honestly, AI is here, most definitely here to stay, and it is advancing very, very quickly. So, I think we have to embrace it, but we do so with caution, and I think we have to look for a responsible use of AI. And Rebecca mentioned this morning, that Vivli have put some great tools in place to help us have that reassurance that, you know, our data is going to be used appropriately. You know, they have a great risk assessment model tool now, and I want to give a shout out to Marcia Levenstein, who I know has put a huge amount of work into that. So thank you, and that really is, you know, very helpful, because it gives us the sense of security that, you know, we can appropriately assess the requests, and we know that when we are sharing data, it's done responsibly. So.
Great, thanks, Paula. And Ben, you talked about persuading people to share data, and a lot of people are put off because of a complicated process. How do you think, or do you think the process is simpler? How do you allow people to get into the process and move things forward?
Yeah, I think from a process standpoint, it's more of a conversation, at least from a company, is that you don't have a choice. We're going to share the data, and so this is a commitment that we have made. The commitment we've made in order to publish. It's a commitment we've made when we register the trial. It's a commitment we've made on our website, and it's a commitment we've made to the patients, and the participants. So that's really the conversation. I think the complications are going to come from some of the things that we're all working towards right now, which are the ability to share images. You know, that's been a complication in the past, and it's one that we continue to have and say pretty much right now, no, we just can't do it. But it's something that's necessary. I think another complication that is coming up and we're trying to address prospectively is what we used to call EMA Policy 70 Phase 2, which was the sharing of clinical trial data as part of a submission to the EMA, and now it's the European Health Data Space, which is going to take that place, and how do we get in front of it? And so excited to hear about the Vivli EU in Amsterdam, and you know, it's nice to be not reactive, be proactive in this, and be able to explain to the company this is why we're part of the Vivli, why we're sharing data through this platform.
Great, thanks, Ben. So we're keeping on track, and we've just got less than 10 minutes, but we do have opportunity to open it up to those in the audience here to ask questions. Julie, have you got a roving mic so people can hear? So put up your hand if you want to ask a question, for any members of the panel.
I had a question for the two investigators, Jonas and Youssef. When you were doing your studies, or you had your students doing your studies, folks working with you, did you have to go back to the sponsors at all, or the data contributors, to clarify aspects of the data? Was there much of an interaction there, or was it more a situation where you got access to the data from Vivli and you were good to go, and there was it was a one-way street? Was there any backwards and forwards? I'm just curious about if there was any interaction.
Yeah, I can get a great question, practical question. So the answer is yes, and I do remember several instances where we were first, to me, at the beginning of every project, the CRF, or the clinical research form for each of the clinical trials, to me, is like gold at the beginning, because that's essentially what was collected. We had few questions about the CRF form as a radiation oncologist. Most of the trials we were analyzing were not meant for the purpose of radiation therapy, but they're investigating drug X, being it an anti-HER2 drug or like a VEGF, anti-VEGF drug. So we had questions on the data specifically for radiation therapy, which luckily was on the CRF, but we had questions on how it was collected, what this coding meant, because each one was coded. And Vivli was very kind to connect us with the right provider of the data, and we got our clarification in a timely manner. So yes, those questions do come up. Yeah.
Okay. Do you want to add as well, Jonas?
For me, it was actually usually very straightforward. So I had very few instances where I had questions about the data. Most of the times it was very obvious from the protocol where this data came from. So for me, it's usually has been very simple to get to the data on the platform.
Thank you both.
Okay, so one more question from here before we go online.
Yeah,
Steve?
Steve Kern I'm a board member with Vivli. And I think both of the clinical fellows gave great examples of the value back to individuals who participated in the trials of the secondary analysis. And I'm curious about how we capitalize that as a message, right? I mean, I personally consented over 1,000 people in clinical trials. And I can tell you that for the most part, people agreed because they felt like they were helping someone else, not that they were helping themselves. And so you both have two really great you have multiple cogent examples of this. And it'd be really interesting to think about how that message gets back to the patients in that trial, right? And whether there's an opportunity to really start to build that message up, because I think it's a huge value that's being underappreciated. And then Ben doesn't have to fight so hard internally because everybody goes, of course, this is a value, see what's happening. So that's just a comment, and I'd be curious to think about how you might do that. Jonas, I'm curious, and I don't know, Julie, if you know the answer to this, how many failed PD-1 trials are in Vivli? Because I'd be curious if you took your biomarkers and went back to a failed trial and looked and see if they enrolled the wrong population, if it might be a real interesting explanatory follow-up to the work that you're doing. And then secondarily, if people start to use it as an enrollment criteria, should they or shouldn't they? Some real interesting things coming from that kind of work. So I don't know if that's something you've looked into or thought about, but just those become the cascade of questions that come out of this kind of work, which I think is really, really, really valuable.
Yeah, maybe. I mean, there are a lot of comments there and big topics.
I have a little comment.
Yeah,
Because you actually made several great points there. In fact, it is a full circle. At the end of the day, we want to use this data in a meaningful way that could affect our patients in a good way. So in many of the questions we tried to address using the Vivli dataset actually came from gray zones in clinical practice. And we realized early on there's not going to be a randomized trial for that specific question that this clinical scenario is posing to us from a radiation therapy perspective, for example. So Vivli was a great partner from that aspect, and it really became a full circle from the clinic and back to the clinic, and along the way with the mentorship that happened. So great points.
Jonas, do you want to add anything?
Yeah, so to your point with the negative trials, I've actually, I have looked into some of the negative trials, and there are signals, I would say, that patient selection could be an issue, but unfortunately for my line of research, many of the large anti-PD-1, PD-L1 trials are missing or are not completely on the platform, so I didn't have the opportunity to really get a comprehensive picture.
Yeah, unfortunately, that still remains a challenge, publishing negative data. We've probably got time for one final question here in the room. Yeah.
Hi, T-Fam with the Gates Foundation. So we've been talking a lot about trial complexity, right? So, studies seem to get more and more complicated. It's a little easier to add, one test to an already existing planned trial than to create, yet another new trial and run it. There's, primary endpoints, secondary endpoints, exploratory endpoints. So I'm just curious, as you're looking at the data, if, this is a case for keeping some of those exploratory endpoints for secondary use.
Okay, Youssef, comment on that?
I think it's a great point. I mean, ideally, definitely, like in terms of evidence from a purist perspective, nothing kind of surpasses a randomized phase 3 trial. So you want to have that. But in daily practice, to get there and be able to accrue and complete the study, it takes a lot of resources. I can tell you from a radiation therapy perspective, a lot of the evidence that we use is actually not generated from randomized phase 3 trials. Good phase 2 data or even secondary analysis could make it to guidelines simply because we don't have anything better to use. So I do believe that a careful handling of the data could be very impactful in the absence of phase 3 trials. If we have the resources to validate it in a randomized trial, that will be great in order to make it standard of care down the line.
I think what T's asking, and I'm just going to try and rephrase this question because we had a lot of conversations over the last couple of days at MRCT about simplifying clinical trials, is if the object of the trial is to look at how the drug works on the tumor, what if they didn't collect any radiation data because it wasn't about radiation, and then you didn't have the ability to actually do this secondary analysis? Is it worth continuing to say, well, we may have a need for radiation data in some other analysis, so we should collect it, or should it be we're trying to simplify these to only answer the questions that we need to answer for the study?
Okay, I think we'll leave it there with 14 seconds. I could see where that was going, so I'm cutting it off because I want to end on time. With 14 seconds left, I think I want to close it, and I want you to thank all our panel members for a great presentation start to the day.